All right, well, welcome everyone to a special live edition of the Coffee with Coker podcast. My name is Mark Rybolt, and I'm going to be moderating our discussion today. We do want to thank everybody for joining in. This was one of those things that was put together a little bit somewhat last minute, as I know things have been rather crazy the last few weeks, and which is why we're here and the topic we're here to talk about. And so we do thank you all for joining in. Just wanted to also let everyone know, since it was put together a little bit last minute, we are going to be making the recording of this session available. So anybody that couldn't join would be able to listen after the fact. It will be coming out in the next couple of days. We'll make sure everyone gets a link to that, and all the folks that follow Coker. And then if you know of someone that may be interested, feel free to pass those links on so they can listen as well. With that, I wanted to jump right in to our topic for the panel discussion today. We did want to make this a little bit more of a free-flowing discussion with our esteemed panelists here, and I'm going to let them introduce themselves here in just a minute. But we, like I said, wanted to make it a little bit more like a panel, because since the topic we're on is there's so much happening literally day to day, and we felt that instead of trying to dissect every single recent development, kind of teeing up a little bit of the discussion around some of the bigger picture items we're seeing, and then provide some observations on some of the things we're working with clients and those healthcare organizations out there that we're monitoring. We thought that may be helpful as a starting point, and then we'll just kind of take it from there. But we are really just talking about some of the things that we think are relevant for healthcare executives in this very unique period of the COVID-19 pandemic. And we're going to have a couple of agenda items. We're not going to go through a lot of lecture or death by PowerPoint, so hopefully that will be welcome for you all. But while we are here, I did want to mention real quick, this is not intended to be any formal counsel or legal advice, and this is again just meant to be discussion, so we wanted to provide that disclaimer. We are joined by a panel of Coker folks, as well as some of our esteemed colleagues from the law firm Frost, Brown and Todd. So I want to let everybody, I'm just going to open it up and let them introduce themselves, and we'll start with our attorney friends, and Chad and Andrew. I'm going to let you guys introduce yourselves real quick, if you don't mind.
Thank you, Mark. I appreciate that. This is Chad Eckhart. I am the chair of Frost, Brown Todd's Healthcare Innovation Team. Our firm represents a number of hospitals, health systems, medical groups of all different specialties and multi-specialty across our 9-state footprint. And we have a number of attorneys that focus on traditional healthcare and innovative options in the healthcare arena. So one of those members is Andrew.
Hey guys, Andrew Johnson here, and I work with Chad on our healthcare innovation team, and particularly we try to help folks come up with innovative solutions in the healthcare field, and in particular the traditional healthcare area. My focus has been on telehealth solutions, and so hopefully I can discuss some of the bigger changes and impact that the recent telehealth restrictions or expansions have had on hospitals and other healthcare providers.
Yeah, thanks, Andrew and Chad. And I wanted to mention, since you referenced telehealth, and we're going to be talking about that in depth here in a minute, we do have a poll that should be coming up on your screen for the participants. Just a quick little poll about telehealth, so feel free to participate in that while we're finishing our intros. And let's go to Max Rybolt, and Max and Richard, let you guys introduce yourselves.
Thank you, Mark, and this is Max Rybolt. I'm President and CEO of Coker Group, and it's a real honor to be on the panel with Chad and Andrew and my colleagues at Coker. I'll just quickly say, as CEO of Coker, and I've been in this role now for over 20 years, and with the firm since 1992, it's never a dull moment. It's one of the reasons at my age I'm still clicking away and doing a little thing, some work. And yet I think it's safe to say I have never encountered anything close to what we are encountering in healthcare, and albeit in our entire country and the entire planet Earth, as what we've been faced with. So hopefully we'll have an informative discussion today, and certainly available to follow up afterward if need be. So thank you very much for attending today. And Richard, I'll throw it over to you.
Thank you very much, Max. My name is Richard Romero. I'm a senior vice president with Coker Group. Spend most of my time on general financial consulting, litigation support, and valuation. And for about the past 10 years, that includes telemedicine, and spend some of my time educating other valuators on how to actually perform valuation services as it relates to healthcare. Just from following telemedicine, really excited about just how telemedicine has served as a key cog in the response to COVID-19. And I think that's just the tip of the iceberg in terms of things to come with telemedicine as a whole.
Great. Well, thank you all. Thanks, Richard. And as we dive into the discussion here, we really just wanted to cover a couple of broad, admittedly, agenda topics. And since a few of you all alluded to telehealth, and then we had the poll question related to telehealth, let's just start there. And Andrew, maybe I'll start with you, but let's just talk for a minute about just generally. I mean, there's been an explosion of telehealth as far as healthcare delivery. So in this world where it's not a new concept, but it's definitely something that's been thrust upon literally all healthcare providers in one way or another. Maybe talk to us about what you've seen, where we're at, and then we'll kind of lead in and talk about maybe some things to look out for, where we're going with this whole telehealth, telemedicine thing.
Sure. Yeah. So, I mean, telehealth or telemedicine, and I'll use those terms interchangeably, but they've really expanded a lot in the last couple of years, even more so in the last 30 days. What I've seen generally has just been a gradual alleviation of restrictions on certain aspects of telehealth, like, for example, where you can provide telehealth, or which providers can provide some of these services and successfully be reimbursed for those services. And so generally, from what I've seen, especially in the last 30 days, we've just seen a huge expansion of restrictions that were initially placed on providers to now allow them to kind of use telehealth or use the tools that were really already there. A lot of the telehealth technology was already there. It was just a matter of kind of the laws and the regulations catching up. And so now that we've had this big expansion, we're seeing providers start to use it outside of the rural areas, which was generally one major restriction that CMS had on providing telehealth. And so that being one, the removal of kind of like the geographic and site limitations, that's kind of expanded the pool of providers that can now see patients using telehealth. And from what I've seen, I'm really, really excited about this happening, because the technology was already there. And I think looking at where we're going in the next 30 days, I think as a response to COVID-19, it's just so important that these restrictions continue to be removed, so that people and providers can see their patients and at the same time provide those services safely, where they don't necessarily need to be at the location of the patient.
Well, that's really interesting, and Richard, maybe you can chime in too, because I know you've been monitoring this. But as you think about the access to care, Andrew, you mentioned rural health and the rural setting. I know telehealth has been pushed as a possible solution for that. Now everybody seems to be cut off. Are we expecting this kind of embracing of telehealth to be something that is here to stay? And what are some of the other things that we need to be thinking about today, even though we're right in the midst of kind of a chaotic or somewhat chaotic uncertain situation, but thinking a little bit more long term, what are some of the things that we at the very least need to have in the back of our minds?
I'll start and certainly allow Andrew to top in there. I think what's interesting with telehealth, and not to go too far down this path, but what we saw, I think, at the beginning of this year was a recognition by CMS that there were certain limitations that prevented just practical care. So we saw some codes that CMS specifically did not call telehealth to allow expansion of service and leveraging of technology to provide patient care. In an emergency situation, as Andrew was saying, some rules that have been pretty stalwart from CMS with regard to initial visits within hospitals having to be in person, some of what we would consider typical hospital-based services for discharges and those types of things. Given the need for providers and leveraging the ability of those providers to provide care geographically, in this emergency, those have been waived just because of sheer need. And I think what has traditionally been a question of patient care, also cost within telemedicine, what we'll see now is with all of this billing data that has come out as a result of this, we'll have a chance to diagnose this, if you will, after the fact. What we'll see is that telemedicine, the limitations that have been placed are probably artificial in a number of circumstances. And so this has been I think a fundamental tipping point that will help with provider shortages and also become in a lot of ways a new modality or standard of care, I should say. It's a tool, not a modality, but a standard of care that will fundamentally change the way we look at how care is provided, whether that be from staffing questions to care to scheduling. So long term, I think that this will allow expansion of limited resources of our providers, but it will also raise a number of questions going forward about how providers are actually performing services, staffing, resources, technology. So a lot of those questions are still going to be fundamental business questions that have to be answered as we go forward.
Yeah, Richard, I completely agree with that. And I think what hesitations some folks have now is trying to balance, how much to invest in telehealth right now, when looking forward, you might see CMS roll back some of the allowances that they've kind of implemented now. So I think that's one big factor that a lot of providers are trying to weigh, determine how much should we invest in telehealth now, when maybe this particular modality or maybe this particular service won't be allowed after this COVID-19 thing is over with.
Now, this is Max, and I have a couple of thoughts relative to that, maybe even for some discussion among the group. I had an email this morning from a hospital client, who, interesting enough, oversees their physician enterprise, pretty good size system and number, I think around 200 employed physicians. And her indication was that, first of all, they were doing about 40% of their volume that they usually do, which is not surprising. And it was essentially all in telehealth, not too much in person for obvious reasons. And I won't say the state, but let me just say it is one of the states that's one of the hot spots, so you can understand that. But the other observation that she had, which I would like to throw out to the group for discussion, is that the patients are still pretty reticent to accept that level of care, notwithstanding the restrictions on movement that we have. Even within that, it was not particularly well received. So I wonder what the panel feels, and obviously some of our attendees may be getting some of the same feedback. Reimbursement is getting better quickly. It is true that these waivers are temporary. One would think that they'll make them permanent because it makes a lot of sense, but that doesn't always mean it'll happen when things get somewhat back to normal. But I'd like to throw it out to our discussion group. What about the patient, and how are they going to receive telehealth, and will this be met with any opposition relative to their portion of the payment for the service, things like that.
Max, I'll start real briefly. I will just say that what studies have found is that I think there's always going to be a portion of the population that is going to want hands-on interface with a doctor physically in the same room, and that's what they believe is appropriate care. We've also seen the complete and inherently some of that correlates with age. However, what we see from reports from Teladoc and others is that what we'll see is a true bond forms through the computer, if you will, with those providers, where this provider that they've never actually physically met in some instances become a primary care provider in a number of ways, even such that they'll select a doctor and they will wait versus having the next available provider perform services for them. So what it says is inherently it can be new, it can be different. So there's always a little bit of hesitancy there. But in a large number of cases, most overcome that and realize that the quality of service is at least as equivalent as an in-person visit. So Max, I think some of that is going to be related to the newness of it, and I think just comfort with technology, but generally the responses are very favorable in the long term.
Yeah, and the only addition I have to that is that we've had a clients come to us with issues about practitioners being prepared and actually being adequately trained to provide telehealth services. And it's not necessarily the medical skills that we're looking to train here. It's more so the people skills, the ability to connect with patients through electronic means. And I think part of the issues that we're going to see right now is perhaps there are providers who are using telehealth for the first time or for the first few times, and perhaps they're not connecting with patients in that way. And it's those soft skills that I think will impact how patients receive care through telehealth. And perhaps that's just one consideration that providers need to think about, because it is great to get the medical skills there, but the patient, of course, still needs to be comfortable, and having that training is still pretty important.
Yeah, and Andrew, I think that's a very good point that, we don't have to get into the weeds of the technology discussion here. But one of the things I know that Coker has looked at going back now a couple of years is the fact that there's a lot of technology out there that relates to telehealth, virtual visits, et cetera. And it's one thing, I guess, to think about, well, there could be a module attached to EHR, or there's capability there. But you also have other considerations, right? You have, what about cybersecurity? What about the linking to the patient records, and then any sort of compliance related variables that may be out there. Right now, we're in the midst of something that's very unique. Again, there's an element of scramble to it, if you will. So I think those types of things may be a little bit more kind of back burner, even though they're relevant. But we're kind of dealing with, hey, we got to respond to the urgent needs, and then we can resolve the things that, yes, we're obviously going to have to come back to. So I believe there will be a number of these things. Just look quite simply at bandwidth. I think I've been one of those to find that I keep getting kicked off my own systems because I'm working from home, and I have kids doing school streaming and taking up most of our data on our Wi-Fi at home. Basic things like that you don't think about. If a physician is trying to see patients, can he have or she have the connectivity that's required in addition to the security and all the other things? And then that same potential issue applies to the patient, right? If a patient is bogged down and can't do a connection with whatever technology tool is being used, I think that's what we're seeing right now, this high utilization of very basic things and common things like FaceTime, visits and Skype visits and those types of just kind of Zoom calls. Those have exploded and become popular. Other forms of social media, even through like Facebook and things like that. And I think it sounds like from the government standpoint, those are okay right now in what we're doing, but how do we follow back up with those? How do those things get documented correctly? How do we ensure the coding is there? And then how do we ultimately make sure we can bill for that appropriately? And then all those other things that I mentioned are in place. So just a couple of observations. Anyone else want to chime in on that before we move on?
This is Chad. I was going to just very quickly mention the driving force of consumerism in healthcare that we've seen over the past 4 or 5 years is a real force that our clients are trying to respond to in a way that healthcare providers never really had to before. And while you have a growing base of consumers in the healthcare market that are very comfortable with these technologies, my 70-year-old parents are calling themselves Zooming boomers now. And so they're comfortable with some of this technology. And I think you're going to find that the consumerism is going to drive the need for these telemedicine services and also start, pushing down the cost that's going to be associated with those and the reimbursements. So I think this is going to be here to stay, and I do believe that it's going to take a little while. The OCR waivers for use of Skype and other modes that you were talking about, from some of the privacy protections that are in place during the emergency, are going to need to be dealt with. So there'll be a little bit of a curtailing of these services moving forward. But I think that once the COVID emergency is dealt with and finished, you're going to find a consumer base that's going to demand the service going forward.
Mark, this is Richard. Just a quick comment tying, I think, what both Andrew and Chad were both saying is that there was an announcement by the commissioner of the FCC this morning looking to fund $200 million for telemedicine equipment to put in place. I think there was already a move from the FCC to expand, to your point, access to broadband to more places, followed up by this announcement today or this morning regarding the purchase of equipment. So as Andrew's comment meant, in terms of the hesitancy to invest because of long-term implications of reimbursement, and then just as Chad was saying, is there's going to be a demand. I think what we're also seeing, not just from the immediate pandemic, but longer-term support both at the federal and state levels in terms of expansion of services, allowing asynchronous visits. I think clearly, as for everybody on the phone, they are on this call, they need to have a strategy for this going forward, because it's not going away, and it is going to become more inherent and a part of what we do in healthcare going forward.
Yeah, I couldn't agree with you more, everyone. And I was just looking over some recent CMS publications, and it's really absolutely incredible. The softening of what has heretofore been fairly resolute restrictions on certain levels of care and types of care via telehealth. Let me just give a couple of quick examples, and I'll be brief because I think it will affect a lot of our audience. So, for example, dialysis patients can now be treated. Some home dialysis patients can be treated through telehealth. Hospice, another one that I don't think we would have ever thought of. Another one would be where there's a requirement for physicians and APPs to perform in-person visits for nursing homes. That's been softened to where it can now be done remotely. I'm sure those who are familiar with coding and reimbursement or have individuals in their organization will want to take note that there's additional codes for reimbursement, particularly for nursing home, an expansion of audio-only services. There's been a removal of the frequency of limits of visits. In some cases, subsequent inpatient visit limit of once every 3 days was in place. The Stark laws, which we're going to talk about here in a minute, I know Chad can hit on that better than I, have been lightened supervision regulations and requirements for physician supervision have been lifted. So if Richard, if you're right, and you're usually right, so I'll say that off the cuff here, and these things are now all of a sudden going to become the norm, then what has happened, and unfortunately it took a pandemic attack in this country, horrible situation admittedly, to cause this, but this has literally changed the face of healthcare. I was telling somebody that today that's looking at a potential lender to provide financing for a new hospital. And the original feasibility study was done 3 or 4 years ago. And the question is there another one needed? And I said, you bet there is, because a third of healthcare, that's just me, is probably going to switch to telemedicine. And hospitals and other providers are going to need to change. They don't need as much. They need more technology. They need more providers, but they don't need more bricks and mortar. They just need a room with, proper telehealth equipment. So I think we have, this is the tip of the iceberg of what's going to happen in healthcare, and our clients, most of which are already getting into it, and I'm sure yours too, Chad and Andrew, are going to see a tremendous paradigm shift. Tremendous.
So let me kind of make it real here for our audience. So on our little poll, which of course we realize this is anecdotal, not remotely scientific, but 70% replied in that said they're operating under some condition of telehealth, and I think that's telling, potentially in a number of ways. But the reality is we've heard story after story from clients and others out in the industry we know that are suffering obviously right now. Hospitals are trying to respond to the urgent high acuity needs of not just COVID patients, but everything else high acuity wise that they have to continue to respond to. I saw yesterday in Georgia, at least, the governor suspended temporarily certificate of need laws. So the healthcare facilities in essence have a license to expand number of beds under their own discretion, things like that. So that's going to be temporary, clearly. But another function that they're dealing with is the financial burden. We've heard story after story of clients and others laying off their employees. They're having to deal with cash flow issues in an era where they have no elective procedures that they're engaging in. The perhaps saving grace for many of them right now, possibly even from a perspective of pure survival, is some form of remote care setting. Is that what you all are seeing? And what can our clients and the audience out there keep in mind as they are starting to think about having to possibly go into some form of survival mode, at least temporarily?
I'll jump in here. It's Andrew. I think from what I'm seeing, I think it goes back to that question of short-term versus long-term investment here. And we've definitely seen providers try to, reallocate some of the resources that they have, whether that's human resources or even telehealth resources. And it starts with that really system-wide evaluation of, what is our capacity to do to undertake or meet our patients' needs. And if you don't have capacity, we've seen some folks in the industry try to look at, very short-term contracts or short-term arrangements with telehealth providers or telehealth servicers, and just ask them to really provide these services in a short-term basis and with the potential for, long-term commitment. And it's really that question of deciding, do we want to jump in this as a long-term investment? And do we want to commit our resources or human resources and perhaps training to this telehealth initiative, knowing that, some of these rules in particular are only effective for the duration of the emergency.
Yeah. Yeah, good points. Well, telehealth is going to be a theme here that's reoccurring throughout not only this discussion, but and subsequent discussions like this. And so we'll probably keep coming back to it. I do want to make sure we're also talking about some of the other things here that are, I think, relevant for our audience. And so let's talk for a second. Max alluded to Stark and some of the kind of temporary things there, but I think generally speaking, as it relates to things like Stark, and as we look at anti-kickback, and then how that perhaps ties to even some of the fair market value, commercially reasonableness guidelines that traditionally govern all of us, and it's something that we all work with our clients on. What are you all seeing? And Chad, maybe I'll let you kick us off here. What are we kind of seeing right now, both in regards to telehealth, but also, just generally, what are some of the activity that's going on that our audience needs to be aware of?
Yeah, no, I'd be happy to talk about that. And when most everybody on the call understands the highly regulated nature of the healthcare industry, and one of the most imposing regulations out there is the Stark Law, the self-referral prohibition for physicians. And anytime a entity is entering into some sort of an arrangement with a physician, which happens on a regular basis, they have to deal with the Stark Law because it's a strict liability statute. And if you run afoul of the Stark Law, meaning that a physician's making a referral for designated health services to an entity in which he or she or an immediate family member has a financial relationship and an exception isn't met, then those monies that are reimbursed by Medicare and Medicaid are subject to recoupment, and also under reporting and return obligations, that self-reporting and returning. So it's imperative that we deal with those. Now, the Stark Law is an extremely complicated statute because of its breadth and its prohibition, and then the depth of the detail and its exceptions. And because of that, you end up with arrangements that, as everybody on the call knows, slow down when you're dealing with physicians. And in this pandemic and in this environment, we don't have the luxury to slow down and navigate these very complicated laws. So as a practitioner in this space from a legal perspective, and I know on behalf of all our clients, getting the blanket waivers that came out at the end of March with respect to the Stark Law are incredibly helpful to the industry and incredibly helpful to allowing the providers to focus on providing care as opposed to dealing with the legal requirements that go along with that. And the intent of the Stark Law is to make sure that that physicians in particular are not inappropriately benefiting themselves through their decision making financially. And in this day and age, the old axiom and the ethical obligations of what got physicians into their practice and is what's really driving them to help right now. And so I think it's appropriate to waive a lot of these requirements. And so talking, if I may, for a couple more minutes about some of the specifics of these waivers, they're retroactive to March 1st, but they're applicable with respect to financial relationships and referrals that are related to the COVID-19 outbreak. And that's really important. They didn't just waive these completely across the board. As we know, Max has said that, some of the people he's been working with are seeing their patient volumes be about 40%. I've talked to some clients and they're down as low as 25%. And it's not, treating COVID-19 in some areas yet. And so those traditional relationships, even though there's fewer of them, they're still ongoing. Those may not relate to COVID-19, and these exceptions wouldn't be applicable to them. But anyway, the department did a really good job of giving some examples of what relates to the COVID-19 outbreak, and that's diagnosis and treatment of the disease, and it's also providing services of doctors and others that aren't necessarily related to that, but are incidental because of the need to treat COVID-19. And you can think of some of the hot spots for that. Ensuring, there's another big part in here that relates to the purposes, is ensuring the ability to address the community needs in this environment. And that is really thoughtful because it goes beyond just the COVID-19 disease and treating it and the virus, but getting to the effects of the stay-at-home orders associated with that and the access to care that telemedicine helps with, but it can't solve all the problems. So you got to be very careful with making sure that the relationship you're looking at does relate to the pandemic. And then the waivers are extremely, there's about 18 of them, and they talk a lot about waiving fair market value requirements with respect to arrangements with physicians, whether it's for office space leases, rental of equipment, items and services that can be provided by physicians, personally performed services by physicians, referrals for patients to home health agencies, to providers in rural settings. All of these things have been loosened so that we can provide the care that's needed. And I'll stop right there, just let some other people chime in, but I kind of wanted to maybe think through this a little bit with respect to, maybe a real situation that's happening, I'm in Cincinnati, it's happening downtown Cincinnati, but I want to pause to see if the panelists want to jump in, share a little bit more, but it might be nice to kind of think about these waivers in a real case scenario.
Yeah, Chad, this is Richard. I was having a discussion the day before yesterday with another consultant at a different firm, and he said, "Well, Stark is dead," and I corrected him and said, "No, it's not." And so I think one of the biggest things that we want to make sure everybody gets across is that, just from my personal view, I think the government has taken a very practical approach in saying we don't want rules and regulations to get in the way of providing care during this public health emergency. And I think that they're trying to be as absolutely flexible as they can to get care where it's needed. Some of the implications that we've seen, ironically, one of my largest clients happens to be a group that works in ICUs, and they staff ICUs across the country. And typically, for example, we'll get into probably a little bit about this a little more, but what they're having to do is they typically work on a shift basis, and they get paid per shift, and then some call coverage time. Well, obviously, ventilator management is a big aspect of ICU care, and I think we've all heard the word ventilator more in the last 30 days than we probably had in our entire lives. And so, in terms of if they're willing to work those additional shifts, if they're able to leverage their capabilities in their own systems and actually to the community, what we're seeing is those are aspects that were never thought about, were never considered as a part of their existing contractual relationships, whether that be as an employee or as an independent contractor. And so the documentation of yes, per COVID-19, all these during this period of time, your compensation is going to be waived. The limitations in your contract are waived. We're going to pay you for the additional services that you're providing. But they're actually having to go through, which is terrific because it's available, first of all, but those entities are also having to go through and making sure that they are documenting what is being done in response to COVID-19, so that at the end of the day, when this is looked at, nowhere in these waivers is it said that fraud is going to be allowed. And so I think that's a key piece to keep in mind. And so as those on the phone that are dealing with this, make sure you're getting good legal counsel with regard to what documentation should be going on now. Take care of patients. Realize that you have amazing flexibility that you've never had in the history of healthcare, at least in my experience, as a result of this. But make sure you're following those things so that you're in the best position should the government ever come knocking on the end. But I think we're seeing reorganization as a whole. I think we're seeing reorganization of resources. Our doctors being put to work from elective surgeries to basic care. And I think we are dealing with some contractual questions that those waivers that we're talking about are key and central to keep those doctors at work providing services to clients in a myriad of locations.
Richard, this is Chatty. Richard, you're exactly right. I love the example that you shared about the ICU and that we need changes to these contracts and talking about the documentation requirements. You know, these ICU physicians may have ventilators that can be, you know, using it, you know, providing to the hospitals and you know, selling those or renting that equipment creates these financial relationships that we're talking about. So these waivers are extremely helpful, especially the very last one that they mentioned, Richard. And you kind of tapped into this a little bit, but you know, there's a for compensation arrangements, which are anything, you know, that we've really generally anything we talk about. It's not an ownership arrangement, but you know, it's a rental of space, rental of equipment, compensating somebody for their services. For those, you have to have a writing, and the document has to meet certain exceptions. And so there's these elements associated with most people on the call are familiar with, and you've mentioned a few of has to be fair market value for the services or the equipment that's being rented, you know, space, etc. It has to be commercially reasonable in some cases, and you know, an agreement has to be written, signed by the parties for a year, and all these other requirements. The final waiver waived the requirement to have that actual writing and signature requirement, but it doesn't, like you say, allow fraud. So you still have to be able to demonstrate what the arrangement is, and particularly how that arrangement meets all of the other requirements of the exception, absent the writing. And so you still need documentation. You may just not need to have that writing, you know, prepared and signed. And I think that gives flexibility to, let's go ahead and we'll you know, rent these ventilators from you, or we're going to get you for more, get you bound to provide more services because of the need here, and we'll deal with the documentation requirements later, which typically you don't do in START. Typically you get the documentation before you start the arrangement. So I think that's a really good practical example of how these waivers are helping allow providers to respond to the pandemic in a more thoughtful and quick manner.
One of the things I want to chime in real quickly on, and I want to make sure we respect everybody's time here. We did have a question, and I thought it was actually extremely helpful comments that were made in the question, but it relates to telehealth kind of.
This is Chad. I did recognize that call or that question come through the chat room, and it was relating to whether or not courts are going to give flexibility to providers in malpractice suits. And so, if I may, I'll share a little bit with respect to what I could expect courts to do in this situation, and it all hinges on malpractice suits hinge on the ability of a physician to provide reasonable services that are not negligent. You know, so you got to provide services that aren't negligent, and the negligence standard is based on a reasonably prudent individual in like circumstances. And because of that standard, you end up with courts having the ability, given the circumstances right now, to adjust what's reasonably prudent in a pandemic versus what's reasonably prudent in a regular time. So they're still bound by prior decisions and cases where they look at facts and say, if these facts are similar to that prior case, we rule in the same way. So we have consistency of the applicability of these laws. But you're in a situation where we don't really have consistency with factual precedents. So you're going to get some flexibility there. And so I thought it might be helpful to respond to that particular question.
Chad, this is Richard. I've just got a quick follow-up question with regard to that. You know, we may have some providers that have not traditionally performed telemedicine. Are there things that providers should be, you know, making calls to their malpractice carriers to ensure that there's coverage for those services? Any guidance that you might want to provide on that specific circumstance or question?
Yeah, I think it's helpful to make sure, and Andrew deals with the telemedicine a little bit more, but when you're looking at the risk mitigation measures, obviously your insurance is number one, and you want to go look at that insurance to see what it covers and what it excludes. And if you're not covered specifically for telehealth or maybe cybersecurity after some of the HIPAA waivers go away, then you're going to want to make sure that you do have coverage for that, because that's what you're buying, is some peace of mind for that. So I think it is prudent to go ahead and take a look at that. And make sure that you have that coverage there, despite the flexibility that you might receive under malpractice standards because of the pandemic.
Andrew, do you have any additional thoughts on that issue in just in general for providers that perhaps are newer to telemedicine or doing it in a different way, that things that they might want to consider as part of this during this pandemic?
Yeah, I think one of the biggest things, and we kind of touched on it today already, which is cybersecurity. I mean, frankly, as we're going through this response to the pandemic, what I'm noticing is that cybersecurity just becomes a massive issue, and I think right now, access to care and patients receiving high quality care is the most paramount thing. But perhaps cybersecurity is not really talked about as much as it should. And so the first thing that comes to mind when I'm thinking about advising a client on this is really just to make that evaluation on the cybersecurity capabilities and resources of the telehealth provider that you're using or servicers that you're using. Just because, frankly, I mean, even though OCR is really relax some of the HIPAA rules, a lot of the HIPAA rules still really apply. Maybe Chad could talk a little bit more about those rules. But cybersecurity, to me, is probably going to be one of the biggest things. And I think one of the clients that I've had a discussion with really came to me and initially thought, with these new HIPAA waivers, can we do X or can we do Y? And I was telling him, no, HIPAA still very much applies, and any sort of cybersecurity requirements that you had before most likely applies now and still.
Hey, can you all hear me now?
Mark, you're on.
Yep.
Yeah, I apologize. I lost connection there for a second. So thanks for keeping it going. Thanks Andrew for those comments. And I did want to we have a few minutes left here, and I want to make sure that we didn't miss a couple of items. Specifically, I'll plug real quick. We may not be able to spend as much time talking about physician compensation, even though we've already talked a little bit about that or around it. I guess I can give a quick plug real quick. We just did another podcast that's coming out, I believe, tomorrow with Justin Chambly, who runs Coker's physician compensation services. And we talked specifically about some of the different arrangements and some of the things we're seeing specifically as it relates to physician compensation and right now with COVID-19. So we'll make sure you all get a referral over to that so you can listen in and also read the article he wrote on that. And one of the things I know we wanted to spend at least a couple minutes talking about here was potential relief. Again, as I alluded to earlier, all organizations, all the clients that we work with are going to go through some degree of some form of struggle and challenging period, hopefully temporarily, hopefully a short period. But there's relief is on the mind of everyone and all organizations out there, and as well as individuals. So maybe if you all will just touch briefly on, we know we have the CARES Act, which is the kind of the general stimulus package that's out there, but there are some other things that have been discussed. We have some SBA, other SBA programs besides CARES Act, and then there's also some discussion around other economic stimulus, potentially something or some things specific to healthcare organizations, medical provider organizations. So would you all like to comment anything on stimulus efforts going on?
This is Max. I'll jump in first and then defer to my distinguished colleagues. I think the basics most everybody understands, which is under 500 employees, it's subject to salary I'm talking about the CARES Act, the loan, the forgivable loan for payroll, utilities, and rent. Interestingly enough, I was talking to a couple of people yesterday with small businesses in healthcare, and they were not all that aware of it. And in particular, one was saying, well, do we qualify? And I said, well, first of all, obviously talk to your banker, and it has to go through the SBA, but it sure would seem like you would. And needless to say, you have to demonstrate and document what it is you're asking for the basis of your loan to be, which is payroll, but it can be both full-time, part-time, independent contractor, quote unquote, employees. And you cannot, certainly the biggest threshold, the largest one is it cannot be to an employee or an independent contractor who makes more than $100,000 per year. So it is based on 2.5 months, but essentially up to 100,000 for an employee. So if you had someone that's making 200, you could only consider 100 of that, and then 2.5 months of that 100,000 pro rata. But when you add it all up, it's an incredible opportunity to mitigate losses and mitigate lost revenue. And as I understand it, it pretty much applies to all small businesses. And again, the major threshold for being a small business is 500 employees or less, which is not that small business, even if you have 500, but nonetheless. SBA, I've done several SBA loans for clients over the years, and frankly, their hoops are quite a bit to jump through at times, and most of these, not surprisingly, have been lifted for this loan. It is repayable if you do not employ the same number of employees that you subjected the loan to for 8 weeks post this period. At least that's the basic understanding that I have. So it's a terrific opportunity for our practices. Probably wouldn't apply to hospitals, obviously, for a lot of reasons, but certainly medical practices should be out front in the applications are ready to be submitted, as I understand it, through a bank that's authorized to the SBA as of tomorrow, as early as tomorrow. So this is very quick turnaround. I'll just stop there and let some of my other colleagues jump in. And in fact, the attorneys in the room might even correct me or certainly embellish what I said in more detail.
Yeah. Max, this is Chad, and you think you hit it. You were spot on. I will share some practical things that I've heard. A lot of our clients have been reaching out with respect to this, Paycheck Protection Program loan. You can go and apply through your banking institution. You likely want to reach out to the current lender, because I've heard lots of banks are not, they just don't have the bandwidth right now to open this up to new lenders, to new borrowers. And I've also heard that there's some speculation that these funds are going to be all dispersed and accounted for by the end of the day on Friday for some banks. So if you haven't put your application together, I would use some time after the next 7 minutes and go ahead and start looking at that, because I think those funds are going to go very quickly.
Yeah, thanks, Chad. And just for anyone that may be listening to this after the fact, as of recording, we're the 2nd of April, so we're referring to Friday as the April 3rd. So hopefully anyone listening after that will have already tuned into that. Any other comments there?
Mark, I was going to just say a few things. A lot of the hospitals and health systems obviously don't meet the requirements of the Small Business Association, and they're not going to be able to take advantage of these loans. But that doesn't mean that there's not provisions that are out there. A large portion of the CARES Act was focused on support for the hospitals and health systems. And given our time, I'll just very quickly mention a few things. there's a few things that really, I think most everybody's heard of the 20% additional payment that Medicare is going to be making for COVID diagnosed patients and treatment for them. So your DRG is going to be, 120% of what it typically is if there's the COVID diagnosis associated with that discharge. There's also the accelerated payment program where hospitals can accelerate 6 months worth of anticipated receivables from Medicare based on historical figures and averages upfront. It's a program that's out there, but it's pretty narrowly used. But the CARES Act did tap into that, and it allows hospitals to get some cash. So we're not trying to defer a little bit of the cash flow concerns. And then repayment would start after 128 days, and I think it goes for about a year until that fully needs to be repaid. But a couple other things that haven't been talked about as much. There's the Public Health and Social Services Emergency Fund, which in the past has been around 1.8 to 2.9 billion dollars, which sounds like a lot. It's a very small department in the Department of Health and Human Services that manages this emergency fund. It got funded in one paragraph of the CARES Act to have $100 billion. And so that's specifically geared towards healthcare related expenses and, interestingly, lost revenues. So that department going from a $3 billion budget to now $100 billion to allocate is still trying to put some guidance out there about how that's going to be implemented, since there wasn't much direction in the CARES Act. But that's going to be a really good source for hospitals to maybe even capture some lost revenues that are associated with this. And finally, I'll just mention just the ability to defer the payment on the employer portion of employment tax, which is for them 6.2%, not having to pay that until the end of the year, and then only having to pay half of it then, and then the other half in the end of 2021 is essentially it's an interest-free loan, and it can be very significant. So obviously organizations want to go ahead and take care, make sure that they're taking advantage of that 6.2% of payroll tax deferment. So there's just a few things in the CARES Act. So I just don't want people on the call to think that there's not the opportunities for hospitals to get some, relief as well.
Well, Chad, that's very helpful, and we had a couple of questions come in, but one directly relating to that, and anybody feel free to jump in. I realize, and we probably don't have enough time to cover this, but maybe just briefly, any thoughts on how health systems specifically can support independent practices and taking advantage of opportunities, i.e. loans through the CARES Act or any of these other stimulus efforts? Any thoughts there?
Well, this is Chad. I mean, there's probably some affiliations associated with those independent groups, whether they're not affiliation of a corporate sense, but some sort of relationships. And I think when you start looking at those relationships, you're going to want to look at the Stark Law waivers and see, what might be able to be done there. So, for instance, there's a waiver of the 15% payment of some of the under the anti-kickback statute. There's the opportunity to provide some technology to other organizations by healthcare systems, as long as they pay 15% of the technology costs that are given, and that's been waived. So there's a few things there, and also thinking about utilizing those independent physicians under arrangements that would otherwise be subject to some of the Stark restrictions. Now you might be able to look at some of those things that they may have been able to help with in the past, but for Stark, and they might be able to help now. You can engage them for services or rental of equipment and things that you may otherwise not have been able to do so.
One thing too that I would add, and maybe this gets us to our final bullet there. I know we're about out of time about the new normal, Mark, but I personally think there's going to be an onslaught of transactions between hospitals and physicians and private equity probably as well when this pandemic starts to subside, hopefully sooner rather than later. I just think that the mindset is going to be changed a lot to where that's the case. I think that negotiations may, between the parties, which I know we're involved in a lot, and so are Todd, are going to take on a different look, maybe a more heightened sense of immediacy to, go ahead and get this done and move on. Just anecdotally, we had a client this week that was engaged in basically a directive to cancel a hospital-based physician contract. I will not even say the specialty, it doesn't matter. And it looked like the termination notice was going to go to in effect, and then of course the negotiations would commence, which is the way we all are used to it happening many times. In other words, there's no agreement reached, and so there's a period where the contract has been terminated. Maybe the group continues to provide the services on a month-to-month basis while the negotiations are going on. And that was the intent here. The group came back to the hospital and basically agreed to what had been offered. And I think it was mostly their existing pay. So no more negotiations, just let's get on with it. Well, that's more of a crisis type thing, but it's interesting. And I don't know how long that contract goes on. I think it was at least 3 years, that they're now bound for 3 years, but at least they have the security, I guess. So there's all kinds of stuff that's going to be going on here. And the new look, as we put it there, is going to be quite new in many respects. So get ready. Yeah. I think we're all going to be finding some new things and interesting dynamics going on, as we've talked about throughout this webinar this afternoon.
Yeah, well, I do appreciate that, and I apologize we don't have enough time to kind of go around, but I think maybe we can save the some other observations for the next episode, which hopefully will come soon. So stay tuned for that. And I apologize we weren't able to get to all of the questions that were submitted, but we'll make sure to follow up with you all to get some specific responses to them, because there were some good questions. So I don't want to ignore those. I do want to thank our panelists. I think it was a great discussion. I want to thank everybody for tuning in. Just real quickly, feel free to follow us. We are continuing, both Coker and Frost Brown Todd are providing updates and continuous information. Coker has a COVID-19 resource center that has all of our content and information that we've been releasing out there. So you can find out more information there, and again, pass on this episode of the podcast and this webinar to others that may find it beneficial. We will hope to follow up with more discussion here soon. But we thank you all for tuning in, and we look forward to continuing the dialogue in future episodes. Thank you all. Have a great day.